Morning. May I?
Hello, morning.
May I share screen just to check my slides?
Yep, sure, go ahead. You're gonna start first, right, later?
Yes, I am.
Okay, I can see your screen, but
How's that?
okay. Now it's okay.
Okay then. Thanks.
You don't have, do you have any videos or audio in your site? Tak ada? Okay.
Yeah, I'm good. Thanks.
Okay, all right. Hi, Hi, Chee Loong.
Sound all right?
Sorry, can you? It's a bit
I
lag.
can hear me.
Yeah, I can hear you, but it's lagging just a little bit.
The sound.
Yeah, okay, now it's okay.
Oh, okay. I'm on a cable internet connection from the medical department, so if it lags, don't know what else to do.
Hi.
Hello, morning.
Morning. Do you want to try your slides, Chee Loong?
Yeah, sure. Hang on a second. Opening it now.
Okay, looks good. No video or audio, right?
No, don't have.
Okay, so we are going to go live now. And just a thing to point out, there's a Q&A box at the bottom. So the questions will come in through the Q&A box. If you can see.
Yeah, got it.
Yep. So I will play a video at 8. Then after that, you can start off the session after the video. David?
Sure.
Okay. So I won't come on anymore.
Hi, David.
Hi, good morning.
Morning.
So I pass the floor to you first.
Okay, thank you.
Sorry, Lee, I didn't bring a hat.
Sorry?
I didn't bring a hat.
It's over. It's okay. I didn't bring a hat either.
Okay, okay.
We'll start at 8. I'll share the video at 8 o'clock.
Sure. Assalamu alaikum wa rahmatullahi wa barakatuh. Greetings of peace. Very good morning to everyone and a warm welcome to another episode of Breakfast at UMHealth. My name is David. I'm a lecturer in the Palliative Care Unit, that's the Adult Palliative Care Unit here at UM. And it's my great pleasure having with me today two esteemed seniors of mine and true veterans of Malaysian palliative care, namely Dr. Chong Lee Ai from the Paediatric Palliative Care team here, a senior consultant, as well as Dr. Lam Chee Loong, who is the head of unit in adult palliative care. And I'll be very excited, looking forward to their talks. For your information, on the 8th of this month of October, the World Hospice and Palliative Care Alliance has proclaimed the World Palliative Care Day under the theme of Leave No One Behind, Equity in Access to Palliative Care. And if we ponder for a moment, it's a very appropriate theme because, as we've learned in the COVID-19 pandemic, there's just so much more to solving our problems than just the technological triumph of developing a vaccine. It's really not worth much until we manage to deal with this huge challenge of delivering it into the deltoids of billions of people. So hence, equity in access to palliative care, likewise, something where we still have a lot of way ahead. And that's very much going to be the topic of our two speakers of today. As usually, we do encourage everyone to pose your questions, seize the opportunity to post your questions to our experts, and we'll try as much as possible to answer them after the talks. Without further ado, it's my great pleasure passing the floor over to Dr. Chong Lee Ai.
Thanks, David. Good morning to all here at Breakfast at FOM. So as David said, it was World Palliative Care Day on the 9th, just over a week ago, and the theme was Leave No One Behind. It's kind of a reminder to us about the children who are voiceless, who are often left behind, and their parents who misunderstand what palliative care is, who will not ask for access to palliative care or even shy away from it. So to ensure that children are not left behind, the International Children's Palliative Care Network, or ICPCN, has also declared 8th of October as a sort of hashtag Hats On for Palliative Care. So this runs together with the World Palliative Care Day, and this is specifically to increase awareness for children. So what we also did was to have our own Hats On for Palliative Care virtual tea party with My Starfish. We invited all our patients to bring a hat, and we asked parents to give us a quote or what they think, what they admired most about their child. So this happened on the 8th. It was quite fun to see them all with their hats on. So we had about 65 children, siblings, parents, and some staff join in on the virtual tea party. And I'm kind of grateful that some of our staff also came to work on the 8th with a hat. And some who didn't have a hat made their own hat, as you can see on the right bottom corner, our very talented ICU team. So in the next 20 minutes or so, I would like to talk about what palliative care is and why children are left behind, and also to highlight the needs that are often not addressed, especially the psychosocial and spiritual needs and goals of care that we do not often explore. And I will illustrate this with cases. So what are the barriers to palliative care? Why are children left behind? I think first and foremost, it's a lack of understanding about what palliative care is, not just among the public or the lay people, parents. It is also among ourselves, our medical fraternity. We don't quite understand what it is. I will share with you what happened when we met a parent of a 14-year-old boy who had just recently relapsed from his cancer. They were not really keen to meet us, and it took them a while. And when we did actually meet them, you could feel the palpable tension in the air, which fortunately after the meeting subsided, and it was a pleasant meeting after that. So what mom said, which was quite striking when we first met her, was, you know, after the relapse, we were offered treatment that controlled the disease. But then they also suggested referral to this. She couldn't even say the word. Aren't they opposites? So I think there's a lot of misunderstanding out there. So there's this assumption that's really hard to shake, that palliative care should not be considered until all curative options are exhausted, when in fact, palliative care should be, offered because it can significantly improve the child's quality of life. And it also should be integrated with curative treatment throughout the course of the illness, regardless of the outcome. So this is how palliative care should look like, going hand in hand with disease modifying treatment of severe illnesses, and weaving in and out according to the needs and along the trajectory until where palliative care becomes the main focus of care at the end of life. And palliative care continues after death with the bereavement of families and parents. So the components of palliative care, the physical, psychological, social, emotional, spiritual part are offered all together from diagnosis to the end of the illness. I think we do fairly well. We pay attention to the physical symptoms and we try and address it. However, I'd like to just highlight pain, especially in this group of children. So children with cerebral palsy who experience pain, 90% of them had ongoing recurrent pain for a year, and only half were receiving any pain-directed treatment. And also about visceral hypergesia in children with severe neurological impairment is not often recognized and hence not treated. However, for this today, I will kind of concentrate more on the psychological and social components that are often neglected in the next few slides. So coming back to barriers to palliative care. So inadequate palliative care options will lead to families often forced to make inappropriate or ill-informed decisions to attempt aggressive curative treatments. So I wonder whether that's because we fear that if we don't offer them the latest up-to-date, treatment or interventions out there, that we will have failed them. And we didn't do our best, perhaps. And meeting children's goals of care, often we forget to find out or to explore what their goals of care are and have a shared decision-making to move forward in the management plan. So, and we have to realize that goals of care can change along the disease trajectory. So do they want to live as long as possible? Talking about quantity versus quality, so that's all matters. Try to live as long as possible. Or is it to live as long as possible and as well as possible? So the quality does matter. Or to live as comfortable as possible, where quality matters more than quantity. So if we address a component well, it will benefit the care outcomes in another component. So for example, if you treat uncontrolled physical symptoms well, especially at the end of life, it will translate into parental long-term grief. So if you don't treat it well, you have prolonged grief. So I think that's the important message here about holistic care, that each mind, body, and spirit of the person needs to be treated simultaneously, so that because they all have a synergistic role to a quality care at the end of the day. So, I mentioned that we ask quotes from parents. So this is about a 7-year-old boy who has acquired encephalopathy and who's quite severely neurologically impaired now. But this is what his mother shared. There are so many times when we need him more than he needs us. He has no clue what he truly does for our soul. I feel that is so profound, and it highlights the depth, the psychological and spiritual depth of our parents, what they have to go through. There were other touching quotes as well, but in the interest of time, we have to move on. So we are pediatricians, we love stories. So I will share a few stories about psychological aspects of patients that go through a serious illness. So this is a 14-year-old girl with metastatic soft tissue tumor. She loves to read. She's got a tablet or a Kindle kind of device. She loves to draw, but very, very shy. So what happened was she was diagnosed with widespread metastases, and she was quite symptomatic at diagnosis. As they were working out the diagnosis, she was had to be admitted to ICU because she was symptomatic. And then she managed to get the diagnosis. She commenced chemotherapy, but in about a month post-discharge from ICU and into treatment, one day she was admitted for treatment, and mom was saying, well, you know, she's been having this chest pain and shortness of breath for a week now, off and on. It comes on most days. So organic causes were excluded, and we were quite puzzled. So we met her. On our first visit, she was quite quiet, very anxious, no eye contact, quite attached to mom. She wouldn't leave mom, mom couldn't leave her, and she wasn't talking very much. So we thought, how do we break the ice? How do we get through to her and build rapport? We thought, well, how about drawing? She loves drawing. So gave her an art block and said, okay, draw anything, you know, draw your family, draw whatever. And then we thought, well, how about we explore what you know, your understanding about your illness is? Is that the reason why, you know, with all this symptoms that you have? So we said, okay, draw your illness. So what she did was she drew herself with hair, smiling, holding on to her phone. And then she drew 30 minutes later what she would look like with no hair now, her corners of her mouth down, obviously very sad. And this was what that sad her was saying. Suddenly teringat, memory kat ICU. Dan tiba-tiba rasa susah nafas. So she herself could you know, could understand the trigger to her panic attacks. And she will say, you know, this was when COVID numbers were slightly higher. So she said, you know, the reports on TV about the numbers and the people in ICU just kind of made her all very anxious. So I think sometimes we forget that what we take for granted is actually quite stressful and traumatic for our patients, and it's quite long lasting. So something to think about. This other girl, 20-year-old with a rare progressive genetic connective tissue disorder. I put these tomatoes out there because that's what she hopes to have, grow some tomatoes in her vegetable garden. So she had a definitive diagnosis confirmed at 15. She had mild symptoms from about 7, more troublesome 13, and coincidentally, her mother died from cancer at that age as well. But she is now kind of at home most of the time, hardly goes out. She is mobile. But she needs help with dressing because of the limited movements of most of her joints. She's got kyphosis, she's got restrictive lung disease, but isn't oxygen dependent at the moment. She's 5 siblings, and dad has since remarried. So as we got to know her a bit more, you know, she will tell us why she's sad, and she used to cry a lot. Family was supportive initially, but, you know, rather dismissive now and less understanding because you can't deal with a person crying for so many years, I guess. So, but now, so what she does is she doesn't cry so loudly, so her family can't hear her, and she wants to have her own space, which is quite hard in this household. But she has learned to talk herself out of it. She says, I just pujuk diri. And she feels orang tak faham, tak biasa beritahu perasaan. So I think we had to try and help her process her feelings and empower her to be more emotional literate, so that she could then express herself better. That's something we often don't explore. Our third patient is a 11-year-old boy with metastatic cancer, and I put this picture, which I will explain a bit later. So he's an only child, very intelligent. He is on the internet, and he's telling us about all the things he reads on the internet. It's quite impressive. So when he presented earlier this year, he presented with severe abdominal pain, it's constipation, he's got a bowel obstruction, because a primary disease was kind of in the abdomen pelvis area. So we were asked to help with pain management then. And surprising, as we had this conversation, he was telling us about pain, and then he said, well, I'm dying inside anyway. I was like, whoa, you know, it's only 11, and that's what the profound, you know, knowledge about his illness. So we said, okay, what's happening inside subsequently on the next visit, because he didn't want to talk about it anymore at that time. So he drew this. You know, it's amazing how COVID has influenced what we think. So he says this virus is in there, and this blue starry thing that depicts coronaviruses. He says that's inside, and they were fighting. And the small little round circles on the right were his white cells. Amazing what kids pick up from what we say, about neutrophils, and you can't have chemo if the neutrophils are down. So his white cells, and these bigger round cells are the hospital, the doctors, and the chemo that he pointed out that was running. And he says they were fighting. And in his words, the aftermath is unknown. Amazing, this boy. So, and the other thing he talked about was his fear in hospital initially, people poking. This is a boy who's never been into hospital, never been sick, and he was getting poked everywhere. And then he had those palpitations, he was feeling uncomfortable when the IV contrast went in during his CT. So again, we don't realize the impact of what we do to our kids. And about his illness, he said, I felt bad because I don't know what is coming. He didn't know he had cancer, but he saw his parents crying and he thought maybe I had bad cancer, for parents to be crying. And then he also reflected that, hey, if I know something, then I'm not scared of it. It's something we should learn to be honest with kids. Right, so we talked to bereaved parents about 2 to 3 years ago, and these are their stories about psychosocial and emotional support. This was a father of a girl who had biliary atresia and died of liver failure. So he said, no, never, they don't. They are more focused on the sickness. There is no counseling for the family. I think they lack in this area. Very insightful of father. I think that is the challenge, to provide emotional support. First, primarily for the patient, second for the parents, and third for the siblings. It's a challenge for medical team, he is telling us. Something we don't know, I think. And another father who died fairly soon after birth. So he said, if there were any problems, let us know early. We parents, we can take it. If somebody had told us, we would understand. They didn't explain to us parents. That I didn't like. My heart aches. My heart is very sore. If they honestly told us, it would be easier for us. And this is 10 months post the death of his child. So for the last bit, the last story about addressing goals. This is a 17-year-old boy with sarcoma of the spine. He had a difficult diagnosis. Took him a while to find his diagnosis, and he presented with cord compression before the diagnosis was confirmed histologically. So he went on to have chemo and radiotherapy over the 9 months. They were quite uncomfortable for him. It was not a pleasant time. However, he completed treatment, so he was so looking forward to, he goes to a boarding school and being with classmates. He even sat for the exam because he missed so much of school that he wanted to remain in the same form as his class, and he passed that, was ready to start school. Unfortunately, he relapsed and he didn't get to go to school, and COVID happened too. So they were all devastated, parents more than him visibly anyway. So parents were very emotional and talked about what is the goal of care now. He relapsed so early, not a good sign. But at that time, they all agreed that it was to live for as long as possible. Let's just go for whatever that's available, even if it's a palliative chemotherapy. So 4 months later, unfortunately, on the second-line chemo, he had progression. And it sounds like he looked like he was having signs of cord compression as well, starting to appear. So it was still localized. So whether the surgeons could totally resect it again and buy him time, or just go with palliative chemotherapy because we know how aggressive it is. So at that time, the goal of care was maybe live as long as possible. I want to maintain power in my legs, but I want to be comfortable also. So if it can be not as risky, it was possible to totally reset, why not? So go for surgery and then chemo. Unfortunately, he had fevers and he had to be admitted. At one episode of decompensated shock, he actually then showed signs that he was deteriorating from his disease. He was increasingly lethargic. He had existential frustration, why is this happening? And I can't control things. It's very emotional, which is quite unlike him. He and Dad had a good moment together when they were on the ward. And he just wanted to go home. So the goal of care from live as long as possible and as well as possible too became a little less. And it was more like, let's be as comfortable as possible. This isn't working so well. So he told Dad that, Mom was very emotional right from the diagnosis. right from relapse, I mean, sort of said, you know, mom has to accept that he will not live long. So this boy knew what was happening. And he told, so dad asked him, well, trying to find out about his unfinished business, was there anything else he needed to tell dad? And he says, no, it's okay. I don't need to share my bank pin yet. You know, there is still time. I think we need to give some, empower these teenagers that, you know, some control that they have as they're deteriorating. But being in hospital, you know, we just have to do BPs, we have to do vital signs, and it was quite horrendous for him. The BP was low, they would make him sit up just so that we could get a nice BP documented on our EMR. And he was very tired, he was just being, you know, disturbed all the time. The ward was noisy, or he seemed to be more sensitive to noise. But dad was worried, he couldn't cope at home. So what do we do? So we thought, well, why don't we try home in hospital? And we didn't know how long he was going to last. So we got mom and sister to do their swabs and stay in the room and try it out so that dad could feel what it was like if he went home. And they found out, well, hospital isn't home. You know, sometimes there are no curtains because it's COVID. We can't wash curtains very often, so there are no curtains. So basically, even though he had his family with him, it wasn't like home. So goal of care was to live as comfortable as possible. Let's go home. So he went home on an ambulance, and he had a moment where he told dad that, oh, that was quite cool. You know, he didn't have, you know, being in a vehicle with a siren going on. He thought it was cool. So this boy was home for about 2 weeks. He had quite a bit of symptoms from his pleural effusion. So he had shortness of breath. That really struggled, but he had help a bit, from a home palliative care service. So I guess my time is up. Summary, I guess it's, you know, the psychosocial and spiritual needs of children and their families are often overlooked, and we need to kind of step up on that and just be mindful to explore patients' goals of care so that we don't keep doing, and sometimes doing less can be more helpful. My last slide, I'll leave you with this quote from Nelson Mandela. There can be no keener revelation of a society's soul than the way it treats its children. Thank you.
Thank you very much, Dr. Chong Lee Ai, for sharing these very precious stories. And hopefully as adults, maybe on and off, we can get our crayons out and share stories. Before we go on to questions, it's my great pleasure once again inviting onto the virtual stage Dr. Lam Chee Loong to give the second talk for today.
Thanks very much, David, and good morning, everyone. Welcome to this celebration, albeit a bit belated, on World Hospice and Palliative Care Day. I'm going to share a little bit about conversations and advanced care planning. Last year's World Palliative Care Day, we did discuss palliative care in Malaysia and suffering and what services existed. So thematically today, I'm just going to cover a different topic, which has to do a bit more with narratives of patient experiences and the whole idea of advanced care planning that I'll touch upon. And I hope that perhaps, yeah, it may just make people think a little bit more when we look after patients, how we can care for people more as a whole, as opposed to their illnesses alone. So what I'm going to cover today, I'm just going to talk about two tales of two patients, just to try and set a little bit of context for advanced care planning. And I have some polls inside, which I hope everyone present today could answer, because I'd really be interested in your perspective. It's not for research, but it's just for the sake of discussion. I'm going to discuss a little bit about advanced care planning and what it is, and go on to talk a little bit more about conversations that will guide treatment of the people we look after. So just to begin with, a quote by Elliot Perlman. He's an Australian author. He wrote a book called The Street Sweeper, and in it, this quote is from where this quote was derived. Wouldn't you want someone to tell your story? Ultimately, it's the best proof there is that we mattered. And what else is life from the time you were born but a struggle to matter, at least to someone? So I'm going to share some stories about people. Their struggles to matter, and I hope their stories matter as well and resonate with each of us in terms of, yeah, who is the person behind the illness and what should we be doing for them. So the first tale was about a lady who I was asked to see. She had a brain tumor. Suffice to say that she had been through a variety of treatments, and it included surgery, radiotherapy, chemotherapy of various forms, but her illness was becoming more refractory. And I was just asked to see her and the husband with regards to an introduction to palliative care. And as Lee Ai shared a little bit earlier, maybe sometimes earlier introductions can be helpful as well, because we can get to know people better along the continuum of illness as opposed to right at the end of illness. But anyway, I went to see her and peered into the room, and there was a beautiful young lady sleeping in her bed, and she had a really devoted husband who was so caring, reading beside her, and he practically never left her side. And I went in and I introduced myself to the husband, and I said hello to the lady as well. I don't know whether she could hear me. She just, perhaps she probably could, because she just opened her eyes briefly, but she really didn't respond verbally in any way. And I said to her husband that, oh, your wife looks very comfortable when she's sleeping. And he said, yeah, he didn't really have concerns about that. And we talked a little bit about what the role of palliative care was. And when I asked him what concerns he had, he said that she was finding it harder to eat and drink. Whenever he put food in her mouth before, she could quite spontaneously chew, swallow it, and there was no difficulty. But in more recent times, the food would just be held in the mouth on occasion, and she wouldn't really initiate a swallow. And he was concerned about nasogastric tubes. And I think on one hand, yeah, many of us think, oh, why not just put an NG tube in? It'll solve the problem. But his concern was that he felt nasogastric tubes were uncomfortable because he had had one previously. And he felt that prior to this, when the wife attended chemotherapy sessions, he felt she recoiled somewhat when she saw people with nasogastric tubes. And from that, he was almost inferring and wondering whether she wanted or would find it acceptable or not. And we discussed that a little bit more, and bless him, he really cared for his wife so dearly. He tried again explaining it, trying to draw it, trying to get a response from the wife. And then I tried to ask her as well, using non-verbal cues, seeing whether she could blink in response, seeing whether she could squeeze my hand in response. But there was no real consistent answer as to whether she would find it acceptable or not. And a few days later, her parents arrived, and I cannot imagine many things worse for a parent than to see your child dying. And I think, I mean, it just feels so unnatural if a parent has to bury a child before they themselves go. And her parents were very much of the opposite opinion. They felt that please, doctor, please put a tube in her. You have to feed my daughter. So I just wondered whether I could do a quick poll among everyone here today, that if you were in this lady's situation, you were perhaps sleeping most of the time, not distressed, not uncomfortable. And this situation arose where you were no longer able to eat and drink through normal means. Would you be able to answer this question? Would you want to have a nasogastric tube put in to feed you? And before you answer it, I would just like to add a few things. In a way, if someone is in the last few weeks or month of life per se, nasogastric tubes, if you look at worldwide recommendations and guidelines from ESPEN, from ASCO, from ESMO, from the NCCN in the US, many of them don't strongly recommend nasogastric tubes because they are not thought to add much to comfort or survival or quality of life. And from a perspective of living and dying and life and death, in a way, when people stop eating and drinking, I guess some people may view that as very natural, as a way to die. And when you start resorting to extraordinary means, putting tubes in, yeah, it's something, it's an extra step that we take typically in medicine. In addition, the other things I would add is that there's no real good proof that it reduces aspiration substantially. And it's costly. I think for many of our patients, if you buy a tin of feed, for example, it will probably last about 3 days, and that probably costs about 100 ringgit. So if you stretch that out to a month, yeah, family members have to pay over 1,000 ringgit. They may be able to get some benefits to help cover the costs, but just interested to know what you think. If you were in this situation, you were this patient, semi-conscious, sleeping, would you want a nasogastric tube inserted? Yeah, can you answer that? Are there any answers so far?
So far, 45% have answered. Okay, 50% of the participants.
Yeah, but some are probably listening in and maybe not answering right off. So can we have a look at the answers, please? Just curious to know what people think. Okay. So 9 out of 47 want an nasogastric tube, 27 don't want, and 11 don't know. And that's fine. I think that just reflects individuality and differences between people. So here I was stuck in between a loving husband of a wife who really thought that maybe the wife wouldn't want it, and the parents who dearly, dearly, desperately wanted her to have a nasogastric tube. And yeah, if you have an opinion, if you have a view about this, it may help to share with the people who care about you and make decisions on behalf of you what your wishes are. Because if you're stuck in this situation and people don't know, then yeah, the doctors are put in a very difficult, uncomfortable position as I was put in here. I won't share what I decided to do at the time, unless you're really interested, in which case, by all means, ask at the end. But I'll just move on a little bit, because this is really just to set a bit of context for advanced care planning. The second story was another young lady I met, a beautiful lady. She was a professional, very well qualified. She ran a business of her own, which she really kind of thrived and enjoyed. And sadly, she too experienced the cancer. She had surgery. She had 3 lines of chemotherapy, and things were getting worse, in her opinion. She was still a candidate for like a 4th-line treatment option. Suffice to say, she could no longer be cured. And she presented to hospital septic, hypotensive, febrile, tachycardic, and the emergency department team did a fabulous job. I mean, they treated her with antibiotics, they gave her fluids, they gave her inotropes, transiently to try and support her blood pressure. And she improved and she recovered. And when I first met her, her sister was by her side, and her sister never left her side practically. And she was mainly troubled by pain in her back, which we discussed some options to try and address. But on a subsequent occasion, when I went back to see her, she said to us, when I woke up from the infection, because she had been unconscious before, my family were all there. And when they were so happy, they were cheering and so delighted to see me wake up. But in my own heart, I cried, I wept. I didn't want to wake up. I stayed at home longer in the hope that I would die and not make it. But I got taken to hospital nevertheless by my concerned family. And they treated me, and here I am. And she shared with us that I know this illness is not going to be cured. I know I'm not going to return to my previous job. I'm not even going to be able to walk, because if you look at my legs now, they're so swollen. I'm not going to be able to get out of bed. And it just struck us that, gosh, what could we do? What should we have done? In a way, everyone did the best thing, and I really don't wrong anyone for it. It's just how medicine is, isn't it? We do our best to preserve life as far as possible. And here was a lady who just thought that this is not a life that I want to live. This is just me stuck in bed, having some pain which the doctors are trying to control. But I'm not going to return to who I was before, my job, my business, my things that were meaningful and important to me. And so another question for all of you, it's the last one I promise, just a one-off, that having heard this lady's view now, if she presented again to a hospital in similar circumstances, septic, unwell, hypotensive, would you treat her infection, bearing in mind what she said? Can we just run that again and see what everyone thinks? Give it maybe about 20-30 seconds. I mean, naturally, having had this conversation with her, we wanted to try and talk to her family members about her view as well. And she said, oh no, don't raise it with them. Please don't raise it with them. They're just going to scold me for giving up. And they're just going to tell me off for not trying to fight and try to persevere with this illness. So what's the response like? 61% will still treat her infections. 12 out of 51, 24% wouldn't, and a small proportion don't know. And that's okay. I think it does raise many issues and challenges, and this is where advanced care planning comes from, isn't it? Because when someone comes to hospital unconscious and you don't know what to do, erring on the side of caution is certainly almost a default position, because once you let someone die, there's no turning back. If you salvage them, you may be able to revisit the discussions and conversations again. And this is really where advanced care planning comes from. Advanced care planning is mainly intended for people who lack capacity to make decisions. So if you're unconscious and we ask you, do you want a nasogastric tube, and we can't get an answer, then yeah, if you had told us in advance what your views are regarding that, what your perspective is, we may have a better idea as doctors to treat how people want to be treated. Likewise, if someone says that I really don't want any more treatment, I know I may die as a result of it in refusing treatment, but that is what I want, then should we not extend that respect for choice and dignity and autonomy to them? In the circumstance, provided the circumstances are recognized and identified and correct. So this is a strict definition of advanced care planning, which came up from a Delphi panel consensus. Advanced care planning is a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal of advanced care planning is to help ensure that people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. It's a very Western concept. It's about, as I mentioned, the extension of autonomy and the respect of autonomy and choice. Because if you ask me a question, do I want antibiotics when I'm awake? And I say yes, would you not extend that same respect to me when I'm unconscious, knowing in advance what I wish for and want? So the key components of care planning are, firstly, it's a process. It's not a one-off discussion. It's not about going to a patient and saying, do you want a nasogastric tube? Yes or no? Because it has to be contextual. And sometimes people change their mind over time. I could say to a nephrologist, oh, I don't want dialysis for my end-stage renal failure. But maybe 3 months later, I may revisit the decision because my life circumstances may have changed. My own perspective about it may be different. So it's not a one-off. It's something that we try to engage people with over a continuum. And we do this with many people we see. I guess most notably in our team, we do it especially for the motor neuron disease patients, because it has a somewhat more predictable illness progressive course, and we can anticipate what may happen in the longer term. The person who we talk about needs to have decision-making capacity, in that they need to have a sound mind to make these decisions. So there shouldn't be a mental condition impairing their decision-making capacity. And if we're not sure about it, then the obligation is on us as the clinicians to test that. And we test that by trying to see whether they can take in information, whether they can retain that information, whether they can weigh up that information and communicate their choice to us. So that's a very simple test. I know many of us engage psychiatric colleagues as well to assist with the process, but it's something that all of us could do, because if they fail at any stage of that process, then they can be deemed to not have decision-making capacity. And again, the duty to us is to try and make sure we should try to restore the capacity as far as possible. It's voluntary. If people don't want to take part in these decisions, it's up to them as well. It's not for us to force things down the throats of the people we look after. And just two other things, it's about two-way information sharing, because we are the clinicians, we are the content knowledge experts. We can certainly make recommendations based on treatments and based on best available evidence, very much the science of medicine. But I think in practicing the art of medicine as well, we have to tailor the treatments to the individual. We have to understand the person and what values they have and what life goals they have, what preferences that they may have in relation to future medical care. So it's about sharing, and it's not really a binary decision about, do you want chemotherapy or not want chemotherapy? Would you like antibiotics or not want antibiotics? Because there are pros and cons to every decision made, and there are consequences down the line that will have to be dealt with. And so the goal really is to ensure that care is consistent in serious and chronic illness. And the outcomes of these discussions, you may have an idea of what wishes people have. I wish to spend my last few days at home. Okay, medically, let's try and make that happen if we are convinced that it's the last few days of patients. And wishes are just wishes. They're not obligations for us to fulfill. So if someone wishes to have more treatment, but they're not suitable, the treatment's likely to do more harm, then there are some instances where a level of medical judgment has to be applied as well. And in advanced care planning, you can make advanced refusals for treatments. I don't want CPR if I have a cardiac arrest. My comfort is most important to me. And if my time comes, I'm ready to meet my maker. They're allowed to refuse treatments, and we have to respect that refusal because that's one of the core principles of medicine and the ethics of medicine, isn't it? We have to respect people's autonomy. If we treat them against their wish, yeah, it can be construed as assault, or in a worst case scenario, perhaps even battery. And alternatively, sometimes they can nominate decision makers. If I'm not able to make a decision on my own, I would like this family member who knows me best, whom I trust, whom I value, who really know me and will honor my wishes and my choices, so they can identify decision makers as well. That's part and parcel of the process. So many people in response to that may then say, oh dear, but Malaysia has no law. How can you practice in that way? And that is absolutely correct. There is no law in Malaysia in regards to advanced care planning. There are guidelines in the MMC ethics guidelines. There's a consent guideline from 2016. And in relation to advanced care directives or living wills, it says that a medical practitioner should refrain from providing treatment or performing any procedure where there is unequivocal written directive by the patients that such treatment or procedure is not to be provided in the circumstances which now apply to the patient. So that's a refusal for treatment. And I think our ethical guidelines do give us some pointers that, yeah, it's okay to respect patients' wishes, except if it's illegal. It must be very clear and it must be applicable for the present circumstances. The patient mustn't have been coerced and must have been competent at the time of its creation. And it needs to be valid and relatively recent. We have this caveat that if medical practitioners, we may treat people still according to our professional judgment in the patient's best interest until legal advice is obtained in emergency. So emergency, in a way, it does give us some wiggle room and leeway to treat first and ask questions later. But I think it is quite clear that it says that we can and we should refrain from treatment if the written directive is unequivocal. And there are pros and cons either way. If Malaysia had a law, yeah, you could get, as it's the case in many other countries and jurisdictions. In the US, certainly, there have been instances where advanced directives have not been followed and doctors have been sued. There are similarly times when advanced directives have been followed and doctors have been sued as well by family members. So I don't think a law necessarily releases us from any obligation otherwise. But this is really just a stance in Malaysia. And just to share two other things before I kind of go through a last story. Sorry, it's taking a bit of time. This is Rita Sharon. She's the founder of a movement in narrative medicine from the University of Columbia in the US. And rather than talking to people about their illnesses, she asks them this question: I need to know a great deal about your body, your health, and your life. Please tell me what you think I ought to know about your situation. So it's a little bit less focused on physical symptomatology and medical histories, but trying to find out a bit more of the person. And it's up to the person who responds to share what is important for the doctor to know. But I accept to a degree, maybe our level of health literacy and education here may not enable our patients to share so easily, and we may need to Malaysianize it. Another thing, I highly recommend this book to everyone who may or may not have read it. Atul Gawande, a very eminent surgeon from the US, wrote this book called Being Mortal. And as a surgeon, he realized that, how can I do better for my patients? And he had many conversations with different clinicians, among them a palliative care doctor called Susan Block, and he came up with these 5 questions that he tries to ask his patients about nowadays. What is your understanding of where you are of your illness? What are your fears or worries for the future? What are your goals and priorities? And that somewhat aligns with what Lee Ai shared a little bit earlier. What's the goal of care for the patients? Is it comfort? Is it life prolongation? Is it cure? But that's often not viable in a vast majority of palliative care circumstances. What outcomes are unacceptable to you? What are you willing to sacrifice and not? And what would a good day look like? Because if we can get a better picture of who this person is, what's important to them, maybe care can be tailored and aligned more to their wishes and hopes as well. And don't stop with these questions, because if someone says, if you ask someone, what are your fears or worries of the future? And they say, I'm worried about dying. That's your opportunity to explore more. What is it about dying that they're worried about? Are they worried about the process? Are they worried about pain? Are they worried about what's going to happen next? Are they worried for their family members and loved ones who they're leaving behind? Are they worried about how the family members are going to cope, or how they're going to tell them about it? It's almost an opportunity to build a rapport with the patient. And it's an opportunity to almost share a moment, which I truly find is quite a privilege when we can go through these things with people, because they are sharing with you their deepest worries and fears sometimes, and not everyone gets an insight to it. If we want to help people, as many of us do in the practice in the field of medicine, then sometimes, besides the evidence-based medicine that we're applying, how do we look after people, care for their personhood, their spirit, their social needs, their other aspects, the other things that make up who they are. So I'm just going to finish on one last story. And this was a conversation with another patient I met. It was a lady who had cancer as well, had come in again. Sepsis is very common. She was treated for sepsis. She didn't go in hospital. She'd been in hospital for about a month. And over that course of time, she developed acute kidney injury, and it necessitated dialysis. And when we were asked to see this lady, the nephrologist had just been. So we went to see her, and when I stepped towards the room, it's this feeling of trepidation it has, isn't it? When you look into a room and there's this huge throng of people inside, and suddenly everyone's staring at you. And this lady was like the matriarch of the family. Her children, sons and daughters, and were all around her, listening intently for everything she might say. And I introduced myself, and I asked her how she was, and she shared a little bit about that. And I said that, oh, I understand the nephrologist had been to see you. And she said, yeah. And I said, what did they say? And she said, oh, they are going to give me dialysis. So I asked her about what she was like before all this. and she used to be at home. I mean, a very house-proud lady who looked after her home very, very well, kept it neat and tidy. And currently she was stuck in bed, and she really missed home because she'd been in hospital for a month. And I said to her that she really wanted to get back on her feet, return to her normal activities. And I said to her that, do you think dialysis is going to do that? And she looked at me, and her family looked at me, and they said, oh, is it not? And I said, well, in a way, this problem that you've been having, the fact that you can't walk anymore, it really came on before your kidney problems arose. I suspect that it's more likely to be associated, a result of your illness, your cancer, as opposed to the recent infection and the kidney injury. And they looked at me and said, but you have to try, doctor, you have to do something. And I said, I think you can try dialysis. I don't really want to stop you doing that because it's important for all of you to know. But I think you should know as well what you want to do. And if I hear you right, you really want to get back home because that's where you want to be. And if you want, you can have some rehabilitation. We can try to get you back on your feet after what you've been through. But this may be more a result of your illness as opposed to the current complication that you're having. And I said to her that do the dialysis by all means. Maybe after a few sessions, you can see whether you feel better as well, because the toxins, the problems from the kidney may improve with dialysis. And if you feel better and you're able to get on your feet, then I'll be equally happy as you are. But if you find it doesn't do what you're hoping it will do, then that's okay. If you don't want to do it anymore, it's perfectly reasonable to stop it as well. If it's going to stop you getting home, if it's not going to help you meet your goals and needs of getting back on your feet, if shuttling you back and forth from dialysis centers isn't really going to restore you to a life, to what you want and what you're hoping for, then maybe you could, as a family, think a little bit more about it. And they were okay with that, and I left them. And a few days later, I heard the lady went home. She had 2 sessions of dialysis. She felt it wasn't helping, and she decided to go home after that. And so, again, I don't know whether she may have gone to a private dialysis center after that. I don't know whether she may have presented to another hospital, not being very happy with what I said or did. But she didn't come back again to UMMC. But it was about trying to have a conversation, exploring her wishes and wants at the same time. So just a few take-home messages, because I think the conversations help us know people better and help us treat them better. And if we fail to plan, we're kind of planning to fail when it comes to people who lose capacity. It's so much easier, I feel, or better if we can treat people how they want to be treated. Otherwise, best interest decisions are usually a lot more challenging and carry a lot more uncertainty in what people may have wanted. The last thing, really, try to align the care that you give to the hopes and goals and priorities of people. Just to close, as the father of modern medicine, William Osler said, the good physician treats the disease, the great physician treats the patient who has the disease. I would make zero claim that I am great in any way. I think I'm still learning. This is a learning process, and I think our patients and the people we meet teach us every day. We just have to be open to listen and to learn to what they have to say. And so to finish, on World Hospice and Palliative Care Day and leaving no one behind, I just hope that we as a body ensure that everyone has access to palliative care, no matter where they live, who they live, what their age or their background. So with that, thank you very much, and I'll stop here.
Thank you very much, Dr. Lam. And that leaves us a few minutes of precious time to answer questions from the chat box. First of all, by Prof. Mary Merritt. Are advanced care plans legally recognized in Malaysia currently? If not, what do we do in practice? Do we still respect prior wishes of patients regarding end-of-life care that have been clearly stated? May I perhaps pass it to Dr. Lam since you touched on it?
That's a really good question, Mary. I think it's really hard to work it properly unless the whole system acknowledges it and we have some systematic way of addressing it in the hospital. In a way, as a step forward, I think it would be good if maybe we form some group to try and make this more workable. As I mentioned earlier, there's no legal recognition per se. We don't have a law like the UK or the US or Australia, Singapore, Taiwan, for example. We don't have a law, but medically, I think we still have an obligation to respect choices. And I've always personally held the stance that our ethical position kind of is almost overrides the law, in that things can be lawful but rather unethical. But it's very rare that you get things that are unlawful that are ethical. So I do believe that it's about choices. I mean, the way we implement it, and it takes a lot of work. And currently, I would say within our service, mainly at the MND manager's desk, it's because they have these conversations and they're almost on standby anytime a patient may present. So if someone really doesn't want intubation, we have to be ready to be able to advise the ED team what to do. We have to be ready to intervene, and that does take a bit of a toll. But I think individual teams need to be responsible for their patients, and it's trying to build a system that would be workable, whereby choice will be respected and we can follow, we can honor people's choices and what they say. I don't know whether that answered the question, but it's something that we would like or we think would be associated with good care anyway. The next question, Shams, what happened to the patient? Did I insert the NG tube in the end? Shams, this, I would say this kind of haunts me in a way. As I said, every decision you make has consequences. Rightly or wrongly, not knowing what the patient wanted, I did go with the parents and put the NG tube. And I'm still somewhat haunted by the husband's look to me after that. The justification was on the basis that we can see whether it helps. It made it a bit more practical from the administration of anticonvulsant medications. Otherwise, we would probably have had to give her infusions of anticonvulsant instead, which practically added a layer of complexity as well. Again, rightly or wrongly, I thought at the time that the bereavement of the parents that they would experience if I didn't put the tube in may have been considerably greater, considering the husband was a little bit on the fence whether to put it in or not. So that's what I decided. But like I said, I'm still somewhat haunted by it. I have always intended to contact the husband again and say to him that, do you know, when that happened on that day, what could I have done differently so that I could learn from him as well? So that's the answer to that. Prof. Aisha, permission to not feed is so much against our dah makan culture. The difficulty for most clinicians to recognize the early signs of active dying. Oh, that's a really good question. Yeah, so one of these things that palliative care people do is we sometimes, when we meet people, try to make some judgment or sense of prognosis. If there are some patterns of illness courses that are described in the literature, I must admit, not terribly evidence-based, but Scott Murray in a paper in the BMJ from, I think it's 1990 or 1991, described different trajectories of illnesses. So the easiest one to predict in is cancer, because cancer progression tends to follow a predictable course. Someone is usually quite fit and well as they deteriorate their performance status reduces. So when someone is practically bedbound, very weak, unable to eat and drink very much, needs help to be turned over in the bed and move, they're usually very near the end of their life, usually, unless something is made them that way. For example, if someone has spinal cord compression, they're bedbound as a result of that, then they may live longer from the cancer prognosis. But yeah, it very much has to be individualized and answered on a case by case basis. You're right. Also, it's very against our makan culture. But again, is nasogastric feeding eating? Sorry, that's just a question I would ask. Because we enjoy food for the taste of the food, the social activity, and I know, yeah, I'm probably talking a different language to the people we look after, because the people we look after are like, eating is so important and essential to life. But it's very different, isn't it? You're effectively just pouring milk into a stomach, and in the vast majority of instances, for cancer at least, people are often not hungry towards the end of life. Usually, it's almost like the body needs less, and that's an observation we have. The other tips for prognosis, yeah, different illnesses, chronic illness like advanced heart failure, advanced renal failure has a different illness trajectory. Things like advanced dementia has a different illness trajectory, but it's important that we recognize them and have conversations with people early on. There are some instances as well where, for example, in advanced dementia of Alzheimer's type, nasogastric feeding is not shown to improve quality of life, improve survival. It's not shown to improve the caregiver's quality of life or well-being or stress or anxiety or depression. So, and that's really been reported in a Cochrane review from, I think it's last year. So it's just important to think that every intervention that we have has pros and cons. And if we talk about being evidence-based, then yeah, perhaps we could and should follow what the evidence says at the same time, because some of these interventions are burdensome too. Okay. Sorry, I'm just conscious we are going over time. Should I go to the open ones? Sorry. Prof. Chan, I would want a nasogastric tube in if it can prevent me from getting dehydrated. Having fluids through an IV is also a poor alternative because these patients always will have poor IV access. Yeah, you'll know that very well as an anesthesiologist. And needs repeat painful IV insertions. Dehydration, I understand, is an underestimated stress to a lot of these patients. Please comment. Yeah, sure. Thank you very much, Prof. Chan. That's a really good point. So I'm not here to say don't do these things. And I think care and treatment has to be individualized. Certainly towards the end of life, last 2 weeks of life, NG tubes, again, not shown to improve survival, not shown to improve quality of life. There is thirst, you're absolutely correct. Thirst can be managed in different ways. You can spray water in someone's mouth. You can give them sips of their favorite drink, be it 100 plus or Coca-Cola. When I worked abroad before, freeze some gin and tonic in an ice cube and just give it to them when they like it. What's your favorite drink? What would you like to have at the time? There may be other ways of dealing with that. Again, dehydration is thought to make people more sleepy, drowsy as they get worse, and there are releases of endogenous endorphins, and sometimes in their unconsciousness, people can be quite blissful as well. It's very case by case, but I would emphasize that mouth care is critical to all. Dry mouth is awful, as you say. If we can moisten the mouth, if we can address it in other ways, there are sometimes alternatives. But Prof. Chan, if you're really insistent and we know that, then yeah, we can really think about it nearer the time. But it's uncomfortable too. I was talking to a friend a few days ago who had a nasogastric tube, and he said that practically every moment he would wake up and feel the tube down his throat, and every time he swallowed, he would feel that tube moving. I don't think it's especially comfortable, but what is the priority? I guess, again, it's being very clear what the priority is. Are you after comfort? Are you after symptom relief that the tube may be conferring? But the vast majority of people don't find tubes very comfortable, except I would say maybe in decompressive situations, and people have intestinal obstruction and a lot of pressure in the intestine. In that instance, it can be quite helpful. Sorry, one more question there. I hope I answered your question, Prof. Chan. Do the illnesses have to be terminal? I am sure not. The misconception that palliative care mainly involves terminal cancers needs eradicating. wider dissemination, accurate information may be helpful, especially to many healthcare professionals, as palliation is almost usually at the bottom of the list. Yeah, you're absolutely right. I think there just aren't enough. There aren't enough of us, and realistically, I often say to people that palliative care cannot cope in the sense that if every individual specialty, all the subspecialties of medicine, all the subspecialties of surgery, for example, pediatrics, in volume alone, you can barely deal with your workloads. If we have to see all your patients as well, then we will need palliation too, I often say. So it's challenging. I think everyone needs some core skills and needs some education to be able to provide a level of basic palliative care across the hospital. That would be a hope of mine anyhow. But thanks for that question, Dr. Chong. Prof. Chan, the surgeons, if they have good quality, non-irritating small lumen tubes, yeah, sure. And I said, it's very individual. And again, if you do decide, and if you're able to tell us at the time that you want the tube, then yeah, we can certainly put it in, and we can keep asking you in subsequent days, is the tube still all right? Is it helping your dehydration? Are you feeling any better for it? That's okay. I often liken tubes. I mean, in the stages of life, if you look maybe 50, 100 years ago, prior to the advent of nasogastric tubes as well, that would almost be how we all die as a society, as a people, and people were a lot more familiar with death at the time, and you could have, yeah, you wouldn't have nasogastric tubes, so you'll probably have your favorite drinks, and you probably have the people who you like and love around your bed, tending to you and helping you, and far more in the know of what to do. Whereas nowadays, death is almost a hospital event, and people are sent to hospital when patients and relatives are unwell. So I'm going to stop there. I think everything's been answered.
Yes, indeed. I think we answered all the questions. And I think for those questions which will crop up afterwards, we can stay in touch personally. And hopefully this is rather the beginning of a more lengthy conversation. And yeah, with that, we've come to the end of 1 hour and 8 minutes. And once again, thanks to the organizers and every one of you who attended this morning and contributed to the discussion. Thanks to the presenters, and hope to see you again in real life, and do attend the next week breakfast at UMHealth. Have a nice day, everyone.
Thank you.
Thank you, everyone.